I'm Cortney Lee. I'm an associate professor in surgery here at UK. I'm an endocrine surgeon by training, so my elective practice focuses on surgery of the thyroid, parathyroid, and adrenal glands. Most patients with thyroid disease are women, so we have a large percentage of our practice that are women. We only deal with thyroid disease, parathyroid disease, and adrenal disease. We do a lot of thyroid cancer within our practice, a lot of nodules, goiter, Graves' disease. Parathyroid disease is from high calcium, and so we see a lot of that. Adrenal nodules are not as common. They don't need surgery as often, but it's a tricky workup process, and so we tend to see those patients as well. Most patients who come to our office have been found, a lot of them incidentally, to have a problem. You know, if you were told your calcium's high and we're going to send you to the surgeon because you have parathyroid disease, you'd be like, I didn't even know I had parathyroids. What are those? When anyone hears they have a nodule or a lump in anything, anywhere in the body, there's you immediately have concern that it might be something. So I think most of their concerns are around that. The nice thing with our practice in thyroid nodules is that my partners and I, we all do our own ultrasound and fine needle aspiration, which is another word for biopsy, in the clinic. Our cytopathologists are fellowship trained in that. They're very experienced with thyroid because we do a lot of that. They come over to the clinic while we're doing the biopsy, so they can tell us what they think right away. And that one-stop shop approach really helps our patient population. A lot of our patients travel from hours and hours away, and if we can try to do as much of that during that initial visit and come up with a plan, I think that puts people at ease. The patients are definitely the most rewarding. Being able to take a patient that has a problem and fix that problem. Seeing them come back to clinic and feel better. Whether you're taking out cancer and you're seeing the peace of mind afterwards, or whether you're taking out a big symptomatic nodule or goiter and the patient's like, I can swallow better, I can breathe better, I didn't know it was bothering me that badly. I had a patient several years ago that came back after parathyroid surgery, and she had that, and she felt bad beforehand, was feeling run down and fatigued and brain fog and whatever, and I said, well, most patients notice some improvement. She came back in a month. She's like, oh, Dr. Lee, I feel so much better. You know, I used to not remember phone numbers, now I can remember them, and you know, it's going on and on. Her little husband's sitting there, and he's like, finally, he's like, Dr. Lee, can you take my parathyroid out too? We wish it worked that way, but it's really nice to take somebody that has a disease like that. You know, parathyroid disease is bad on the bones and the kidneys and can even be linked to some heart issues. So there's other reasons we do it, but the small one of making someone feel better with the outpatient sort of surgery, most of our surgeries are outpatient, it's nice, it's rewarding.